given the size of the effect, it does seem to be the vitamin D status is the dominant risk factor for poor outcomes.
The UK's Health Secretary has just ordered the country's National Health Institute to conduct a third review into the role vitamin D may play in our body's defence against COVID-19. Dr. Gareth Davies is one of hundreds of researchers and health professionals upset by earlier dismissals of vitamin D by UK health bodies.
Vitamin stands for vital amino acid, and these are supposed to be amino acids that our bodies can't produce, so vitamin C, vitamin D, vitamin E, etc. But in fact, vitamin D is not a vitamin because we do produce it in strong sunlight. It's produced by UV rays in the summer or strong sunlight in the tropics, and it converts cholesterol in skin cells into various forms of vitamin D. There are actually 5 different molecules that together form the vitamin D group, and it's a hormone. So when I started looking into vitamin D about a year ago, I was doing it for personal reasons, and I was incredibly surprised at how many diseases it's involved with. From cancer to diabetes to respiratory disorders, pretty much across the board. If there's a disease that can have vitamin D involved, it's involved.
Dr. Davis and others conducted their own study into the association between vitamin D levels and COVID-19 mortality rates.
We looked purely at the number of reported deaths and the number of reported recoveries. Now, in the early days of a novel pathogen, those figures are almost certainly going to be coming from hospitals because you don't have anyone else testing or have any other way of knowing whether people are infected. So it's a pretty reliable pair of figures that you can look at.
So you looked at latitudes, and in low latitudes, high sunlight, high vitamin D, you found lower fatalities in COVID outbreaks?
In order to prove cause, we had to do something that's quite unusual in the medical field. So we did, I'm a physicist by training, and so we did a proof which is much more common in physics. It's called a hypothetico-deductive proof, where we take 2 models. We took a causal model where vitamin D is modelled to be causal in outcomes, and a contrasting model where it's not causal. And from those 2 models, we can then make certain predictions. And we were able to make 19 verifiable and falsifiable predictions, which we could then go out to the observed data and compare and see which of the models was closer to the truth. And the results are really quite striking. The causal model only 16 of the 19 predictions were testable, but of those 16, all 16 were confirmed by for the causal model, and all 16 were falsified for the acausal model. So that's pretty, on its own, is really quite extraordinary. It's quite a bold claim to be making.
The claim being that vitamin D has a causal relationship with poor COVID-19 outcomes. How does that work?
So people that have severe COVID-19 reactions are being admitted to ICUs with something called ARDS, or ARDS-like symptoms, which is acute respiratory distress syndrome. And their lungs are having a very, very severe inflammatory response to the disease. And the system that controls inflammation and blood pressures is called the renin-angiotensin system. You can think of it as having an accelerator and a brake. And the accelerator is depressed when you have an infection, and the brake starts to be depressed just to keep that acceleration from getting out of control. The virus, SARS-CoV-2, attacks something called ACE2, which is a cell receptor, and that is the brake, and the virus breaks the brake. So you end up with a RAS that has an accelerator but a broken brake, and you get something called a cytokine storm, where the inflammatory response is out of control and there's nothing to bring it back under control.
Dr. Richard Quinton is a consultant endocrinologist. During the height of the UK's first outbreak, he found himself in a position to do a more hands-on study at the Royal Victoria Infirmary in Newcastle.
So it was a small study. In fact, it wasn't even a study, it was a treatment, which we decided to undertake, and we then audited it and shared our findings both locally and to the wider community. We just decided that we would identify vitamin D deficiency in COVID-19 patients as part of their routine workup, and then we would suggest a clinical management package which was available for physicians to pick up and use if they wanted. And that management package included a single oral dose of vitamin D of between 1 and 200,000 units, depending on the admission level, that was designed to normalize vitamin D levels within a few days, based on what we know from previous dosing studies. And then this was invariably followed up by a maintenance dose. This is what we did. Clearly, it wasn't a randomized trial. There was no control group. It was a treatment. But then we went back and had audited what happened. There's some interesting things. So first of all, we found out that patients had come in, about 10% had absolutely shockingly low vitamin D levels, virtually below the detection limit for the assay. Second, we found that if you came in with a very low D level, you were likely to end up on intensive care. And actually, other bigger studies subsequently have shown that patients with lower D levels, the lower it is, the likely you are to die. In terms of death, the other interesting thing we found was that if you had a decent vitamin D level, so above 75 nanomole per liter, which is that recommended by the American Endocrine Society, then actually you virtually don't die. So apart from if you're under the age of 90, in our hospital, nobody who comes in with a vitamin D level above 75 nanomole per liter has died so far, which is quite a striking finding.
I'm taking 50 micrograms of vitamin D a day. That's 2 tablets of the normal tablets. Is that a good idea?
Yes, so 50 micrograms, that's 2,000 units. Maybe you could manage with a little less, maybe you could manage with 25 micrograms, 1,000 units, but you're not going to do yourself any harm by that. I think the important thing is that you're taking some, and the important thing is that the dose is 20 to 25 micrograms, 800 to 1,000 units at least. If you take a little bit more, that's not going to do you any harm. In fact, if you're from an ethnic minority, darker skinned, you should almost certainly should take a bit more anyway.
So in simple terms, low vitamin D, poor outcome?
Pretty much, yeah. And it's not, it's important to be clear as well, it's not the only factor. There are some people who will have poor outcomes irrespective of their vitamin D status. That's the nature of life, unfortunately. But it does seem, given the size of the effect that we're seeing, it does seem to be that vitamin D status is the dominant risk factor for poor outcomes. The good news is, of course, that's something that we can modify cheaply and easily, and it's scalable, and it's something that people can take control of themselves today.
Thanks so much for watching. Don't forget to like, comment and subscribe, and hit the bell button below for notifications. We'll see you next time.